You're staring at pages of textbook symptoms, trying to commit dozens of disconnected side effects to memory for the next exam. But on the NCLEX and the hospital floor, a memorized list won't help you when 3 patients are crashing at once. Rote memorization fails because it doesn't teach you how to prioritize. To safely manage these patients, you have to look at the hormonal axis centered in the adrenal cortex. This gland regulates the body's stress responses, fluid balance, and metabolism through the release of cortisol and aldosterone. Once you stop trying to memorize symptoms and start understanding the underlying hormonal drivers, the correct clinical interventions follow logically. Think of adrenal disorders as a physiological seesaw. When the body produces a massive excess of these hormones, you get Cushing's disease. And when the adrenal cortex is destroyed, leaving a critical deficit of those same hormones, you get Addison's disease. Because these conditions are physiological opposites, mastering this seesaw model means you can predict the lab values and nursing priorities for one disease simply by inverting the rules of the other. Let's map these extreme differences head-to-head, starting with how each disease manipulates fluid volume and vital signs. In Cushing's, an overabundance of hormones triggers massive sodium and water retention. Blood volume expands, causing severe hypertension and dependent edema. This makes volume control your primary nursing priority. You'll be tracking strict intake and output, monitoring daily weights, and enforcing sodium restrictions to prevent fluid overload and heart failure. Addison's presents the exact opposite. The hormone deficit causes the body to dump sodium and water. Dehydration sets in rapidly, and blood pressure drops. This severe hypotension is the clinical hallmark of an acute adrenal crisis. As a nurse, you are balancing the threat of chronic fluid overload in Cushing's against the immediate risk of hypovolemic shock in Addison's. These 2 disorders also completely invert electrolyte and blood glucose values. The Cushing's disease lab profile includes hypernatremia, hypokalemia, and hyperglycemia. Again, because Addison's is a hormone deficiency, the lab results flip. You'll see hyponatremia, hyperkalemia, and hypoglycemia. Using this inverse logic gives you a reliable tool to deduce correct lab values on exams without relying on memory alone. These metabolic shifts visually alter the patient's body in highly distinct ways. Cushing's is known for moon face, truncal obesity, and the buffalo hump. While these signs are highly visible, they represent chronic metabolic changes rather than immediate clinical emergencies. Conversely, Addison's presents with significant weight loss and a distinct bronzing of the skin and mucous membranes as the pituitary gland overworks. The hidden danger in Cushing's is glucocorticoid excess, severely suppressing the immune system. A patient can develop a lethal infection without ever running a fever. For these patients, meticulous skincare is a priority, and you must treat even minor baseline changes as a potential sign of sepsis. Physical signs like moon face or bronzing are important for identification, but a nurse's priority remains invisible threats, like masked infections that compromise patient safety. The most acute emergency is an Addisonian crisis, triggered when a compromised body faces sudden stress, trauma, or abrupt steroid withdrawal. Without cortisol and aldosterone, vascular tone collapses and glucose levels crash. To stabilize a crashing patient, you must immediately establish IV access for rapid volume replacement with 0.9% sodium chloride and administer an IV steroid bolus. Because Addison's patients can die quickly from hypovolemic shock, massive volume replacement and IV steroids are the absolute top priorities. You can apply this seesaw concept directly to tricky prioritization scenarios. If a patient presents with hyperkalemia and hypotension, they're in an Addisonian crisis. The answer is always immediate IV fluids and steroids. If you see hypertension, hyperglycemia, and subtle signs of infection, the threat is a Cushing's exacerbation, requiring strict glucose and fluid control. Remember, Cushing's threats are slow and wet, chronic fluid overload, and silent infections. Addison's threats are fast and dry, rapid hypovolemic shock. By mapping hormones on the adrenal seesaw rather than memorizing isolated symptom lists, you can identify the underlying mechanism and execute the correct